to the next keynote address that will be delivered by Professor James and Mills. It is a recorded presentation, but Professor Mills will be with us to answer questions. Professor James and Mills is Deputy Director and Provost of the London School of Hygiene and Tropical Medicine, and Professor of Health Economics and Policy. She studied at St. Hilda's College, Oxford, graduating in History and Economics. She joined the London School of Hygiene and Tropical Medicine and became a professor in 1995 and Deputy Director and Provost in 2012. She's a worldwide authority on health economics with a particular focus on creating efficient and equitable health systems in low and middle income countries. She has held the position of President of the International Health Economics Association. She has researched and published widely in the fields of health economics and health systems in low and middle income countries. She has a CBE for services to medicine and is a fellow of the UK Academy of Medical Sciences. She was elected a fellow of the Royal Society in 2013, and 2 years later, she was made a Dame in the Queen's New Year Honours for services to international health. So I'm truly privileged to ask her to make this presentation, which will be in the form of a recording. And as I mentioned, she will be with us live to answer questions. Over to you, to the technical team.
Many thanks for this opportunity to speak at this webinar. And I'm really honoured to have the opportunity to talk about adaptable, responsive and equitable health systems and the impact of COVID-19. I must apologise for not doing this live. You may have seen that we've had a number of storms in the UK recently, and the power supply to my house has been unreliable, and I didn't want this presentation to crash in the middle. But I do hope to be available to take the Q&A afterwards. So what I want to cover in this talk is the health system and health system goals and variation in health systems across the world, providing a bit of backdrop to health systems in general. And then I'll come on to talk about the health system impact of COVID-19 and speculate on the future shape of a health system. So firstly, what is a health system? People often complain that they're really not sure what a health system is. So I thought I'd start by a brief definition that health system is all organizations, institutions and resources that produce actions whose primary purpose is to improve health. WHO has defined relevant health systems goals back in 2000, and they're generic, but still relevant today. So 3 goals: good health, both in its absolute level and its distribution across individuals and groups; fairness in financial contributions, in other words, that people should pay according to ability to pay; and responsiveness to people's expectations, both in the level of responsiveness and its distribution. More recently, this has been framed within the context of universal health coverage, ensuring that everyone can access good quality care, which is now a target within the Sustainable Development Goals. Also more recently, global health security has become considered as another important health system goals, defined as the activities needed to minimize the risk and impact of acute public health events that endanger health across geographical boundaries. And this focus on health security is, of course, a response to global waves of infectious disease, starting especially with SARS in 2003 and now with COVID. This emphasis on global health security has led to a concern with adaptability and resilience of health systems. Resilience, the capacity of health actors, institutions, and populations to prepare for and effectively respond to crises, maintain core functions when a crisis hits, and informed by lessons learned during the crisis, reorganize if conditions require it. But we need resilience in the face of crises and pandemics, but we also need to recognize that health systems face many challenges, and therefore what might be called everyday resilience is important. Ability to be resilient in the face of routine and multiple challenges. In addressing health systems, I'm going to have in mind its four main functions. Financing, conventionally divided into raising revenue, raising income for health services, pooling it so that it's pooled across population groups and the risk is shared amongst that group, and then purchasing, making sure that health services are purchased or resources are allocated to meet the needs of particular population groups. Second area, service provision. The third, resource generation, making sure the human resources, physical capital, pharmaceuticals, etc. are available. And then the fourth, stewardship, concern for the functioning of the entire system, including within that regulation. So these functions are provided in a system characterized by four main players. In the top left-hand corner, the population and patients who seek care from health providers and may pay them directly. The providers of services who provide those services. And then thirdly, the pooling and purchasing agencies who may receive money from people, give them financial protection, and reimburse providers for services. And then on the right-hand bottom corner, the government and professional bodies who both handle some of the payments and also have the responsibility for regulating the entire system. What I've just talked about has more of an economic lens, looks at the health system as flows of services and patients. But we can also see health systems as social institutions. They're complex social and geopolitical institutions with different sets of relationships, for example, between provider and patient, employer and employee, between different providers. And in this context, I want to particularly emphasize the importance of trust, which has been shown up as a real consideration in the COVID pandemic. The trust of patients or population in professionals, or of people in government, or providers in government. Health systems may also be seen as a demonstration of social solidarity. It's frequently said within Western Europe, for example, that health systems are a manifestation of a society's willingness to invest in solidarity. But health systems can also be seen as a means of embedding human rights, the human right to good health and to access to healthcare. I've introduced health systems very generically, but they are hugely diverse across the world. For example, one can look at differences in spending patterns. In this figure from the WHO, ranging from less than $50 per spending per capita to way over $2,000. It's not just absolute levels of spending that varies, but also how money for health services are raised. So this shows the distribution of health expenditure by sources of finance across different country income groups. In a low-income country, you see a dominance of out-of-pocket payments. That's the red pie in the pie chart, with a smaller proportion covered by national tax and social health insurance, and a significant but still a minority share coming from donors, from external funding. At the other extreme, in high-income countries, you see a great majority of health system funding coming through mandated payments, either through mandatory taxation or through mandatory social health insurance systems, and a much smaller proportion coming from out-of-pocket payments. And then between those two country extremes, you see the lower middle income countries and upper middle income countries with a falling share of out-of-pocket payments and a rising share of mandatory payments. So clearly the impact of COVID will vary hugely depending on the extent to which a health system is financed out of pocket or financed by government and mandatory insurance systems. Other dimensions of health systems also vary by country income level. And at the risk of gross generalization, I summarize some typical structures on this slide. So for example, in low-income countries, financing a limited share of government revenue, high share from donors and out-of-pocket payments, as I've just shown. Pooling is mainly for those who can access public services. Services are provided by hierarchical management with very limited formal priority setting, and service delivery tends to be fragmented with a large informal sector and a relatively small formal sector. At the other extreme, in high-income countries, a high share of mandatory funding, low share of out-of-pocket payment, universal coverage almost everywhere, often with a single pool, like that of the National Health Service in the UK that covers the whole population. There's much more formal priority setting processes, decisions on what services should be made available to the population, especially via the means of contracts between purchasers and providers. And service delivery is largely formal and regulated with strong professional control. And then in the middle, with the middle income countries, you have a more diverse pattern, mix of different sources, mix of different pools, often with different healthcare benefits for different pools, different healthcare arrangements for different pools, and a somewhat fragmented pattern of service delivery with various public and private formal sectors, and still quite a significant unregulated sector. So I mention these differences because the impact of COVID will be different across these different country settings, and we need to keep that in mind. So before I get on to talk specifically about COVID, I want to mention and summarize the common health system challenges across the world that pre-existed COVID. Common across all countries is that resources are limited relative to spending opportunities. Obviously, to the extent that's true, will be far more the case for low-income countries than it is for high-income countries. But even in the rich world, we're very conscious of the inability to finance all health services that people would like to have access to. There are inequities in financial protection, in access to services, and in service use. And again, those differences exist in high-income countries as well as in low-income countries, even if the magnitude of the inequalities differ between different high-income countries. There are inefficiencies in the mix of services and in service delivery. So, for example, overprescription of drugs, overuse of antibiotics, even in the poorest countries as well as in the richest countries. There are the challenges of globalization, with health worker migration, challenges in meeting health worker needs, the speed of spread of infectious disease we've seen with SARS and COVID. Publicly managed health systems are often seen as unresponsive and bureaucratic. This has been the case pre-COVID, but a very recent article in The Economist emphasized the challenges and what's been going on. The quote, clunky, costly, highly regulated health systems are being shaken up by firms that target patients directly, meet them where they are, and give them more control on how to access care. And I'm going to come back to that later in the context of COVID. So this provides the backdrop for the impact of COVID on health systems. And I've structured this by the framework I presented earlier, looking at populations and patients, providers, pooling and purchasing agencies, and government and professional bodies. And in the boxes, I summarize the bullet points that I'm now going to cover in the next 4 slides. So firstly, the impact on population and patients. There's been reduced access to care. For example, that may have happened because people have been asked to work from home and services are less accessible to them, or it may be because they've fallen out of employment and their healthcare coverage was associated with their employment. There's been a reluctance to seek care, whether because of fear of infection at health facilities or awareness that health facilities have been overburdened with COVID treatments. There have been worsened health inequalities. We've seen the inequality information about the impact of COVID on different population groups, for example, by ethnicity within the UK, but also worsened health inequalities because as people fall out of employment, as poverty increases, that accentuates health inequalities. And then there have been increased needs because of COVID, because of long COVID, because of the mental health consequences of COVID. There have been the non-COVID unmet needs, and of course, the increased needs as a result of increased poverty. Secondly, the impact on providers of services, most obviously perhaps in the death from COVID of providers, in illness, in burnout related to COVID because of the huge pressures on health providers. We've seen the balance of provision pivoted to COVID and a reduced ability to provide other services. For example, a recent review showed that across 20 countries, healthcare utilization decreased by an overall median of 37%. There's been accelerated online provision of professional services and self-monitoring. In the UK, for example, a lot of GP consultations have moved online, and there's been greater reliance on self-monitoring of chronic conditions and less frequent follow-up at health facility. There's also been accelerated growth of healthcare as a consumer product. We've become used to going to the pharmacy to pick up our tests or to get treatment. That's a pre-existing trend, but one that I think has become much more widely known and accepted. And then increased online training and education, perhaps the silver lining in that training and education has been more accessible by going online. Thirdly, impact on pooling and purchasing agencies. There's been the reduced insurance coverage as people's employment decreases, seen, for example, in the US. Pooling and purchasing agencies have seen an enforced change in priorities, having to devote huge volumes of their resources to deal with COVID, which has led to the backlog of non-COVID treatments. These agencies have had to adapt to a more diverse provider market and new entrants, as a lot more firms have come in offering diagnostic tests or treatments. And also, I think COVID has accentuated the problems of disinformation on healthcare products, particularly with the attention paid to vaccines, to vaccine hesitancy, the anti-vax attitudes, and to information about treatments and what treatments might be used for COVID. And then finally, impact on government and professional bodies. Obviously, first and foremost, the huge cost burden of COVID, especially for governments who have the resources to spend and to divert to COVID. De facto, an increased role of government, which has been to a greater or lesser degree a comfortable increase for governments. Very visible conflicts and coordination challenges between agencies and levels of government, perhaps tested coordination within the health system as never before. And disagreements, certainly in the UK, between what should be a central role and what might be a local role, with, for example, initial decisions favouring central action rather than use of the British system of local government and primary care. A lack of real-time data for decision-making and rapid development of online systems of collecting case data and of informing individual behaviour. And increased tension between societal and individual needs and preferences in decisions on lockdown, when to relax lockdown, and what approach to take to COVID. Within this context, I want to focus especially on the implications of COVID for the approach to public health. Generic health systems frameworks in theory encompass public health, but it tends to be ignored. And it's very clear that COVID has highlighted the importance of the public health element of the health system. Things like surveillance, case finding, influencing health behaviours, vaccinations, things that a long time ago we paid a lot of attention to, but which has been ignored in recent years. And COVID has also highlighted the critical relationship to the primary care level of the health system, not just the public health system, but also the primary care level and its role in dealing with immediate population needs. If one looks at the health system's literature, there's been limited research and evidence on the public health system. It's clear that it's strongly influenced by constitutional arrangements, particularly the distribution of powers between central government and local levels. Arrangements for healthcare and public health are not necessarily the same. For example, local government has a key role in public health in the UK, but the health services are centrally organised and financed. And there's variation across countries in what functions are considered within government scope. Pre-COVID, this has begun to receive greater attention. And for example, there's been recent exploration comparisons in the EU by the European Observatory. This table sets out the organisation of local public health institutions in 3 European countries. In the UK, for example, in England, there are public health departments in local governments at the local municipal level with a high degree of autonomy, no formal upward reporting, and responsible for the planning, commissioning and delivery of local public health services. In France, in contrast, there's no formal organisation, but rather loose networks of NGOs, local governments and local health insurance offices. In Germany, in contrast, a lot of local public health offices at municipal level, largely autonomous and with a wide range of health protection and public health responsibilities. And it's interesting to note that in the early months of the epidemic, Germany was particularly able to use the resources that it had within its local public health offices, whereas in contrast, the British government chose to act at the national level rather than to make use of the public health departments and the GPs, though that's now changed to some extent. More broadly at local level, there are a huge number of agencies that need coordination. And I've taken this diagram from the US CDC, showing all private, public and voluntary agencies that contribute to the delivery of essential public health services within a jurisdiction. And you can see how many different entities need coordinating, organising. And I think this demonstrates how much more thinking and analysis there needs to be on a local public health system and how it can best respond to an emergency such as COVID. So, to conclude on the long-term impact of COVID, I think it's challenged health system capacity and coordination as never before, but it provides an opportunity to reconceptualize health systems and strengthen research on neglected issues, especially public health functions. And it requires all countries to reflect on how they govern, finance, and provide essential public health functions in order to shape a more adaptable, responsive, and equitable health system. So what might be the future shape of health systems post-COVID? And this obviously is hugely speculative. I think they'll be more decentralized. There'll be more initiative in the hands of patients, households, communities, and local agencies, a trend we've seen coming anyway, but which COVID will accentuate. There'll be a more diverse provider market, greater participation of private sector agencies directly interacting with clients, not via a professional gateway. I think we'll probably see that coming in more rapidly in lower middle income countries, since the ability of professionals to slow down the pace of change is greater in higher income countries. I think there'll be much greater online advice, monitoring and support to maintain healthy lifestyles, accentuating the pre-COVID trend. I think that governments and professional bodies like medical and nursing associations will struggle to regulate and coordinate. And this will need new approaches fitting the digital age and particularly addressing the challenging issue of data governance. I hope that we'll see stronger national and local public health systems, for example, with effective early warning, surveillance and management of infectious disease, more coordinated global, national and local agencies, and standing research capacity that is able to rapidly respond as new pandemics hit us, as they surely will in future. And as I said, this is not going to be purely driven by COVID, but I think COVID has accentuated the speed of change and reinforced what was happening anyway. Thank you.
Thank you very much, Professor Mills. I think we have a few questions on the chat box, which can be projected by Randy. Yes. Professor Madhumanar, would you like to elaborate on this or read it out?
Let me read it out. What I said is, in any unforeseen event of the pandemic magnitude, there are winners and losers. We often look at the losers with sympathy. At the other end, there are those who became exceptionally rich and powerful, while the latter is not focused in many inquiries.
Thank you very much. And that's a really interesting question and a really important one. And I think that what has particularly concerned us in the UK is the issue of the award of contracts, the extent to which there are private sector agencies that have benefited hugely, and that the process of awarding very, very valuable tenders at the central level has not followed the due process that we would normally require. I think I would not accept necessarily that this been ignored, but of course, anything that involves money and power can be difficult to challenge and is not always looked into. I agree with that, but I definitely think it should be called out, especially where public procurement procedures or where there are other ways in which the rich and the powerful have benefited and others have lost.
Thank you, dear man.
Thank you for that. If you can, there's another question. It is actually from me. In decision making for future regarding investing in health system strengthening, if we focus on a resource poor settings, since you have done many studies in such areas, what are the factors that should be taken into account to help them, help such a country prioritize the needs?
As an economist by training, I have to say first and foremost, it's to allocate your resources in a way that will provide greatest returns. So criteria like cost effectiveness and so on is a good approach to that. But I'm not that purist in how I approach that, because I think one has to recognize that there are other aspects that we value about healthcare other than just the cost in relation to the effects, and that there are many effects that are less easy to quantify, particularly what one might call the caring function of the health system, that a particular procedure may not have such visible health effects, but the act of caring in itself is a benefit of the health system, and that those are less quantifiable benefits. But nonetheless, allowing for some vagueness around the margins, I would say that cost effectiveness and to choose the interventions and the approaches that give you the greatest improvement in health, given the resources invested, is the best guide to action.
Thank you. Yeah, we do have another question from Professor Priyantais. Would you like to read it out? Or?
Well, it's just this idea of equity. I mean, in this whole reconceptualization, and I think you had a slide about differences in resources across countries, but also perhaps within countries. I mean, yeah.
Yes, yes, and I think the issue of the challenges facing resource poor countries are huge. I mean, if we think even in the rich world that we have to prioritize and ration, then far more that is the case for countries with fewer resources available to them. I think that to the extent that I suggested there is a long-term trend towards decentralization and initiative at the local level, I think to me, the main need is to ensure financial protection, because we know that affordability, if with decentralization, the risk is that people who can afford to get services do so, and those who don't have money to pay then cannot access services. I think with the spread of financial protection at local level, I'm then more comfortable about having a decentralized arrangement where people make their own choices on where to get care, whether through a public primary care system or whether by going to the pharmacy with due protection against what they can obtain there. There's obviously the issue that it's not just a concern about equity in terms of access to money to pay for care, it's also a concern about access to education and the information that people have to act with, and that the richer you are, the better educated you tend to be, and the more able you may be to take decisions. So I accept that within a decentralized system where the power of choice is more in people's hands, that there is nonetheless still a significant issue of equity in terms of people's ability to make those choices. But I do think that the key emphasis ought to be on providing financial protection.
Can I ask another question, Nadira?
Please do. Yes.
So Anne, the question is about agility also. Maybe your decentralization will improve agility. But with COVID, I mean, there have been these sudden rises in cases, and then the drops, and sometimes it looks like health systems have been playing catch up. I mean, any thoughts about how that kind of thing will improve in the future, or is it just that people have to learn lessons and sort of move on?
So I would hope that where agility is needed, and I fully agree with you that in the case of particularly infectious diseases, you need that. I would hope that the preference should indeed be for decentralizing action, because especially also with an infectious disease where your circumstances are different across a country, and that there are limits on the ability to which central decision making can be as flexible as if you allow local decision making. But I think the key really is the local information. Well, it's twofold. It's the local decision makers allocating decision-making authority at the local level, and it's also making sure that you have the information available in order to act on. And I think certainly I think having information available that it should be possible to develop improved local information systems. And certainly some of the actions we've seen in the UK to do with vaccination coverage and so on has been primarily to do with drawing on local resources and local relationships. So, for example, addressing the low vaccination coverage in an Orthodox Jewish community in North London through drawing on their own local organizations that provided ambulance services to interact with them over vaccination. Similar stories in other parts of London to do with accessing ethnic minority groups who weren't being reached by the more formal services. And all of that has to happen locally. So I think I'm more optimistic than you. I think COVID has shown the benefit of that local flexibility and autonomy, and I hope that it isn't suppressed by a national desire to retain control, which is what we actually do see in the UK.
I think we have some time left in the session, don't we, Nadira?
Yes, we do. If
Yeah.
there are any questions, please type in. Anybody, either panelist or
So, and just
Yeah.
to engage you again, I mean, this does not only affect health, but also health guidelines issued, right? So there have been a lot of concerns that the educational system would have fared better if local education authorities were allowed to take decisions about when to open schools and shut them. That discussion has taken place in Sri Lanka, perhaps in other parts of the world also. So that's another example of the benefit of decentralization. Would you think? Yeah.
Yeah, that's an interesting example, and I didn't know that was true in Sri Lanka. I think in all of these discussions in terms of centralization and decentralization, it's important to think about a country's pre-existing structures, levels of government, which level has the responsibility for what, and then who are the powerful players. So I think in responding to your question, one needs to understand what are the influences on local decision makers on schools and whose needs would they take into account. I mean, we know in some countries, for example, where the teachers' unions are extremely powerful, they've actually preferred to prioritize safety and have kept schools closed for a very long time. In other settings, maybe parents may be more powerful and maybe ensure that schools are kept open. So I think you need to think about the balance of power and who has what responsibility, and then what sorts of decisions will that come to at the local level. But also, I think in the area of education, there's this huge challenge with COVID in terms of how do you weight the benefits of education to children versus the risk of infection, and then also what role do children play in the continuation in the transmission of COVID. And I think certainly in the UK, that's been a real dilemma, balancing the sort of value of vaccination against the low risk that COVID presents to children versus the ability of school children to provide a reservoir of infection that then infects others. And I don't think we have any easy answers to how to manage that dilemma. And certainly it's one that involves both a whole host of practical, moral, ethical, and other issues. A very interesting area.
Chair?
Yes,
Nandi,
you have a question?
I have put down a question for the last speaker. I think it is applicable to Dame Mills also.
Please go ahead. Yeah.
Yeah, the question is why a global commission has not been appointed so far, despite the the magnitude of misinformation and divisions of opinion regarding the origins of the COVID and questions about its recurrence in the future. It's a kind of a general question, but why it has been delayed so far? Otherwise, a lot of things should have been clarified through it.
Yes, and that's not a question that I feel myself particularly well positioned to answer, except that I think that these issues of the origin of infections get bound up with both national and global politics. And whatever one may think about the sort of technical merit of a global commission, in the end, whether it happens or not, will be strongly influenced by global politics and the particular needs of particular governments to point the finger at particular times. So I suppose I simply accept in terms of the relationship between politics and science that it's an always fascinating interchange, and that one always has to allow for the influence of politics, whether that's at global or national level, the influence of politics on decision making in the area of health and indeed other areas.
Thank you.
Thank you, Professor Mills.
Nadira,
Yes.
Nadira, Professor Piris has his hand up. Yeah.
Oh, sorry, I didn't see. Yes, Professor Piris.
No, I just wanted to address that point about the Global Commission and the origins. I mean, the WHO had a group that went, investigated that, and they came out with a report, which was extremely detailed, extremely useful. Now, of course, it didn't achieve everything, right? As I told you in my talk, WHO doesn't have power to go and demand things of countries, but within those constraints, they did a great job. And if they had been allowed to continue, because that was meant to be the first part of the investigation, and they were going to have follow-up. Now, unfortunately, global politics just blew that apart. And I'm afraid, I'm sad to say, the WHO Director General also, I think because he's looking to be re-elected, also bowed to that international pressure. I'm being very frank here. So that was the problem. It was really global politics. I'm not saying that, you know, China is totally transparent. I mean, they could have been much more transparent, but there's a lot of blame to go around. Thank you.
Sorry, Professor Piris, can I ask Professor Piris a question now that he is here? Actually, this is something that came out in the early days of the pandemic, and you can answer as well. You know, there were a whole list of things with relative merits for combating the pandemic, like sort of close schools, close restaurants, wear masks, and various things like that. I mean, how scientific is that? I mean, has there been any work done on it so that, you know, the next time there is some infectious disease sort of spread like this, governments and policymakers are a bit more savvy about sort of what needs to be done and, you know, what are the greatest risks? I mean, Professor Piris did mention about masks, but there are a whole other range of things like when should you close schools, when should you close businesses, when should you close pubs and things like that, right?
Shall I have a go first and then I'll hand over. Yeah, I'll have a Dr. Piris. I think it's been one of the really positive things about the pandemic has been the response of the scientific community and how rapidly knowledge has been developed. And admittedly, there's always going to be, it's never going to be as fast as one would like because it just takes time to collect the evidence. But I think that the body of knowledge on those sorts of things you list, things like masks and so on, has improved enormously over the course of the epidemic and will be of great value in the future. And I think a number of misconceptions have been corrected. What I think is, to me, is one of the most fascinating issues is not the intervention by intervention evidence base, but more the combination of interventions. Because I suppose as a health systems person, by background, I'm always aware that no intervention is delivered in isolation. It's always a mix of different things. So the question is, how do they interact, and what is the relative value of one mix of things versus another mix of things? And that's where I think there's been a huge development in modeling skills. And whatever one may think about modeling, it certainly provides a very valuable way of understanding the implications and understanding where we need better information or where better information actually wouldn't make a difference, that the course of action is clear. So I think that's been, in a sense, one of the positive things about the pandemic, the fact that scientific knowledge has developed so fast, and also in a way that is accessible. I mean, the huge development of open science, open data, the preprints published quickly. I mean, all of that, I think, has been great progress and puts us in a good position for future occurrences of something like COVID.
Thank you so much to Professor Mills for sharing your knowledge and thoughts.